Now, although the whole description of the lesion given to us in the patient box is helpful, there are some key descriptive words used that will allow us to narrow down our diagnosis. The first is that this lesion is irregular. This is a big clue for us when diagnosing, and honestly a big red flag as a description for a skin lesion. Irregular borders for most pathology lesions tend to be more concerning and can indicate a more serious, possibly malignant condition. Another big clue is the fact that the color is described as dark and light brown. The fact that the color of the lesion is not homogeneous is a big indicator to what our diagnosis is, and unfortunately another red flag descriptor when it comes to the seriousness of the lesion. Now, based on the image, the entire description, the location of the lesion, and especially those key descriptive words, irregular and the two colors, we know that this is unfortunately melanoma. Now, although you've certainly heard of melanoma, let's still go over some information about it. This is a malignancy of melanocytic differentiation, and it's the third most common skin cancer. The risk factors for melanoma include being fair-skinned, a family history of melanoma, a tendency to sunburn or freckle easily, history of a blistering sunburn early in life, and being immunocompromised. This is most often seen in patients 40 to 70 years of age, like our patient, but is more common in older males. This can be seen cutaneously and mucosally, and high-risk sites are the back, arms, neck, and scalp, places that usually get sunburned. Now, the common clinical signs for melanoma are known as the ABCDEs: asymmetry, border irregularity, color variation, diameter greater than 6 millimeters, and evolving in size or color. Now, just from our description, we were given at least 3 of these. The borders are irregular, the color does vary, and the diameter is greater than 6 millimeters. We don't have an exact timeline of how this lesion has changed, but it certainly has evolved and grown over time to end up looking like this. Now, there are different types of melanoma depending on their location and their growth pattern, and they can vary in appearance. Treatment of this condition includes surgical excision with a 1 to 2 centimeter margin around the lesion and close clinical follow-up, so we want to do that as well. Now, prognosis depends on the depth of invasion and the site. This is definitely our correct diagnosis for this patient, but let's go through the other answer choices and discuss what they are and how they're similar and different from melanoma. We'll start with the basal cell carcinoma. Now, this is a malignancy of surface epithelial origin that arises from the basal cells of the epidermis, and it's the most common skin cancer. This is most common in those over 40 with a fair complexion, and risk factors include chronic and intermittent sun exposure and frequent sunburns. Now, basal cell carcinoma can be seen on any cutaneous site but affects the head and neck 80% of the time, with the middle 1/3 of the face or the mask area being the most common location. There are a variety of types of basal cell carcinoma, but the most common presentation is as a firm, painless papular nodule that is slow growing and has a central umbilication. This lesion often ulcerates and has rolled borders. They have no hair within them, and they're pearly or like opalescent when they're pressed. These lesions also have a history of intermittent bleeding and then healing, making the patient think that they've scratched the lesion. This is treated via scalpel excision, radiation therapy, or Mohs micrographically controlled surgery, and the prognosis is actually usually excellent. Now, how is this similar and how is this different from melanoma? These are both malignancies of the skin that need to be treated accordingly. The risk factors for the two are similar, being fair skin, lots of sun exposure, meaning that the locations are usually similar as well, sun-exposed areas. They're both typically asymptomatic for the patient, but these are different in many ways, and they're actually not usually confused for each other. This is a malignancy of basal cells and not of melanocytes. Basal cell carcinoma presents very differently than melanoma, and it doesn't follow those ABCDEs. This is a round, raised, well-demarcated lesion and not a flat, irregular lesion that's non-homogeneous in color. This has a central umbilication, and it often bleeds, which is also not seen in melanoma, and this tends to have a much better prognosis. Next, we have a melanotic macule. Now, this was probably the trickiest answer choice, as this is another lesion caused by melanocytes that can present very similarly to a melanoma, especially an early melanoma. These are common and benign, harmless lesions that are round to oval and are typically 7 millimeters or less. When they form, they're known to achieve their maximum dimension rapidly, and then they remain constant. These lesions are not dependent on sun exposure and can be found on the skin and intraorally. They have well-demarcated margins and are uniformly tan to dark brown. They basically are just a flat area of darker skin, almost like a flat mole or a large freckle. No treatment is indicated unless for aesthetic reasons, but since early melanoma lesions can have similar appearances, they may be removed by excision biopsy to test them. Now, how is this similar and how is this different from melanoma? Now, these are both flat melanocytic lesions that can present very similarly and can be located in similar areas. So more importantly, how are they different and how would we tell them apart? Now, this is a benign, harmless lesion and not a malignancy that typically has a poor prognosis. These are also not associated with sun exposure. These are typically smaller lesions under or 7 millimeters, and once they reach their maximum size, they do not continue to grow or change, unlike the evolving descriptor of melanoma. These lesions do not change over time. Now, melanotic macules also have regular, well-defined borders and are homogeneous in color, unlike the irregular borders and mixed colors that we saw in our patient's melanoma lesion. This requires no treatment, while melanoma certainly does. Next, we have a keratoacanthoma. Now, this is a benign skin tumor that typically occurs on sun-exposed areas of the body, especially the head, neck, and extremities. They often begin in a hair follicle, with the kerato referring to keratin that makes up hair, and they're most common in older men. These lesions are typically caused by sun exposure, but can be due to other causes such as human papillomavirus or an injury to the skin. Clinically, they're raised, dome-shaped, and rapidly growing with a central keratin plug. These are solitary lesions that are sharply demarcated, erythematous, or skin-colored, with a similar appearance to a squamous cell carcinoma, but not a melanoma. They can be locally destructive and can cause scarring, so surgical excision is the recommended treatment. Now, how are these similar? Both of these lesions typically appear in the same areas and can be caused by sun exposure, and they both are surgically excised, but that's about it for the similarities. This is a benign lesion and not a malignancy. This begins in a hair follicle and is not associated with melanocytes. These diagnoses can have different etiologies and risk factors, so although they both can be linked to sun exposure, they're not always both linked to, well, this is not always linked to sun exposure, but melanoma is. And the two also present very differently. This is a raised, sharply demarcated lesion with a central keratin plug, rather than a flat, light and dark brown lesion with irregular borders. So they look very different. So when we know that whenever we have a lesion on the skin that has irregular borders, has color variation, and it's quite large, we know to suspect melanoma, especially if the patient is fair-skinned, has a history of sunburns, or has a family history of melanoma. It's always better to know your ABCDEs and recognize them and assume that a lesion is melanoma than to be incorrect and misdiagnose a malignant lesion. We have this 20-year-old male coming in for an exam, and we see this measly impacted lower right third molar on the panoramic image, and it has a large and well-defined unilocular radiolucency surrounding the crown of the tooth. There's no sign of clinical eruption, and then there's also a lack of arch space present. We're asked which condition is the patient most likely presenting with. Now let's narrow in on some of the details that were given to us so we can point out the specific clues that will allow us to make a diagnosis. One is the fact that this is affecting the lower right third molar. So all lesions have particular areas that they are most common in, and this lesion in particular that we're going to talk about most commonly affects this tooth. So when you see this tooth, you should always consider this lesion that we're going to discuss. Also, the fact of how it's being described. We see this well-defined unilocular radiolucency surrounding the crown of the tooth. So the fact that it's well-defined and unilocular allows us to narrow it down. Also, the fact that where it is specifically found on the tooth, that it surrounds the crown of the tooth. That is another really important detail to point us toward our diagnosis of a dentigerous cyst. And if we look at this picture I've attached, we can kind of see how it fits the description. So this picture, we see this in a second molar. It's not actually a third molar, but you can see that we have this well-defined unilocular radiolucency surrounding the crown of the tooth. That's exactly what you're seeing here. Now, the dentigerous cyst is the most common developmental odontogenic cyst and is a very, very common cyst to see. It develops due to the accumulation of fluid between the crown and the reduced enamel epithelium, which eventually forms the epithelial line to that cervical area. So this is a pretty easy lesion to be able to spot. So it's always associated with an unerupted tooth, and it's always attaching to that cervical area, almost like a little bubble, like that cyst. And it's most common in the mandibular third molar. That's the most common tooth, and we saw that mandibular third molar is what was being affected in this question. It's also commonly seen in your maxillary canine, your maxillary third molar, and mandibular second premolars. Let's talk about the other answer choices, what they are, and how they're similar and different from a dentigerous cyst. So we'll start with an odontoma. And an odontoma is a tumor of odontogenic epithelium and odontogenic ectomesenchyme. And there are two forms. There's complex and compound. So I've attached a picture of each. So on the left, the picture is the complex odontoma, and on the right, it is a compound odontoma. Now, both of these are made up of tooth tissue, tooth structure. But on the left, we see that this is just a big calcified mass, and that is made up of just tooth structure that is just cementum enamel, and that's why it's so bright. On the right, we see more of these tiny little teeth that form, and that is also tooth structure. So I just want to clarify that they're both made of tooth structures. That's why they're called odontomas, but they are different. So we'll start first talking about complex. Now, complex, they are radiographically appearing as a radiopaque calcified mass, like we said, with the same density of tooth. It has this narrow radiolucent rim and is overlying an impacted tooth, and it's usually seen in the posterior jaw, just like our picture shows. Now, radiographically, we'll talk about compound, which is the picture on the right. Radiographically, we see this collection of small malformed teeth, like I said, also surrounded by a radiolucent rim. And it's known as a bag of teeth because that's kind of what it looks like. You have this little rim, and inside you have these tiny malformed teeth. Now, comparing to complex, we see compound usually in the anterior jaw. So complex we see posteriorly, compound we see anteriorly. Now, how is this similar and how is this different to a dentigerous cyst? It's similar in the fact that we see this in younger patients, so the average age is about 14, and it also may be associated with a failure of tooth eruption. So remember, dentigerous cyst was always seen in an unerupted tooth, so that's a common feature between the two. Now, how is this different? This is an odontogenic tumor, not an odontogenic cyst, so those are different. And the radiographic appearance is very different between these two, as well as the location on the tooth. So these are tooth tissues, but they're not associated with a specific area, like attaching to the cervical lesion of a tooth. So it's not that bubble always attached to a tooth like we saw for the dentigerous cyst. And they look very different radiographically. Now let's move on to the primordial cyst. So this is almost kind of like the opposite of a dentigerous cyst. So this is a rare developmental cyst that is thought to be histogenetically derived from degenerating tooth bud epithelium. And it develops in place of a tooth before any mineralized material is deposited. So clinically, any tooth can be affected, but what's important for making this diagnosis is that there has to be no history of extractions or surgery in the area. That is mandatory for this diagnosis. So we see this in place of a tooth where a tooth might be, but there never was a tooth and there was never anything extracted. So that's how you know what you're seeing. Also, histopathologically, this is very similar to an odontogenic keratocyst. Some people think they're the same, that's some controversy there, but that's how they present. And radiographically, as you can see in this image, it's a unilocular radiolucency always seen in an area of a missing tooth. Now, so how is this similar to a dentigerous cyst? The fact that it is also a developmental cyst, but even though this one is much rarer than that dentigerous cyst, but how are they different? Now, rather than always being attached to a tooth, like we saw for dentigerous cyst, that was a very important thing to make the diagnosis, this is always present in the absence of a tooth. So that's how you would definitely be able to tell the two apart. Now let's talk about the traumatic bone cyst. Now a traumatic bone cyst is also known as a simple bone cyst or a hemorrhagic bone cyst, and it's actually an empty or fluid-filled bone cavity. So it's not actually a true cyst, it's more of a pseudocyst because it lacks that epithelial lining that we always see in a cyst and would see in a dentigerous cyst. This has an unknown etiology, but is thought to be due to trauma, why it's called a traumatic bone cyst, causing hematoma but not fracture. So without subsequent organization and repair of that hematoma, there is this liquefaction process occurring, and that's why we usually get this liquid in this lesion. Now clinically, this is seen in the first to second decades. There's no gender predilection in the jaws, and it's usually seen in the posterior mandible and in the symphysis lesion area of the mandible. Now this is typically painless and typically we don't see any expansion. Radiographically we have this well delineated, usually unilocular but can be multilocular, and it often scallops between the roots. So that's a very common feature. It's not necessarily something that if you see scalloping it has to be this, but we often see this scalloping. So it's a big characteristic. Now how is this similar and how is this different from a dentigerous cyst? It's similar in the fact that it's seen in pretty young patients. It's most common in the posterior mandible, so like how the dentigerous cyst was most common in that mandibular third molar, that's your posterior mandible. Now, how is this different? Now, this, once again, is not really a cyst, it's a pseudocyst. It doesn't have that epithelial lining. And also the fact that it has an environmental cause. So the dentigerous cyst was a developmental cyst. Nothing is causing that cyst. But in a traumatic bone cyst, there is an environmental cause. You would have trauma or some incident like that causing it. So whenever we see this description of the well-defined unilocular radiolucency surrounding the crown of that tooth, it's always cupping into that cervical area, or whenever we see a picture like this, we need to be able to know that this is always going to be a dentigerous cyst. 30-year-old female who says, "I keep getting these sores in my mouth." She has celiac disease, and we're given this image to look at how one of these sores is presenting. And we're asked, each of the following is a likely characteristic of the most likely diagnosis except one. Which one is the exception? Now, before we're able to figure out which of these answer choices is not a likely characteristic of the most likely diagnosis, we need to determine what the most likely diagnosis is in the first place. And to do that, we'll mainly be looking at this image that's given to us. In this image, we see a round lesion on the buccal mucosa with a whitish yellow central area surrounded by erythema. Just based on this presentation, we should be able to make our diagnosis, but in case we can't, we're given another helpful clue in the patient box: the fact that this patient keeps getting these sores in her mouth. The fact that this sore is not a one-time issue, but is instead a recurring problem, and the fact that it's not just one lasting sore, but the reoccurrence of multiple sores, really allows us to finalize our diagnosis. This patient is definitely experiencing aphthous ulcers. Now, before we directly answer the question, let's talk a little bit more about these lesions. Aphthous ulcers are also commonly known as canker sores and are common lesions with an unknown pathogenesis. They're believed to have an immune-mediated process and are also associated with possible triggers such as stress, local trauma, menstrual cycle. These are seen most commonly in children and young adults and can present as minor, major, or herpetiform aphthous ulcers. Minor aphthous ulcers are the most common form. These have the fewest recurrences and the shortest duration for the lesions. They're found almost exclusively on the non-keratinized mucosa and are commonly seen on the buccal mucosa, labial mucosa, ventral tongue, floor of the mouth, and soft palate. Clinically, they present as 1 to 5 painful, round to oval ulcers, 3 to 10 millimeters in diameter. They're surrounded by a characteristic erythematous halo and will heal without scarring in 7 to 14 days. Major aphthous ulcers are larger than minor lesions, have a longer duration per episode, and can present with 1 to 10 lesions that heal in 2 to 6 weeks, often with scarring. These are found most commonly on the labial mucosa, soft palate, and near the tonsils. Herpetiform aphthous ulcers have the greatest number of lesions and most frequent recurrences. The individual lesions are small, may be seen on any mucosal surface, and have a superficial resemblance to primary herpes simplex virus, which is why they're called herpetiform. Now, aphthous ulcers are diagnosed based on their clinical presentation and are treated via topical corticosteroids. These must be applied early in the course of the disease as a thin film multiple times per day. But back to the question. Now, based on everything we just discussed about aphthous ulcers or canker sores, we know that the answer choice that is not a likely characteristic would be C, may be accompanied by fever. The presentation of these lesions does not come along with any other systemic symptoms or presentations, as these lesions are localized to the oral cavity. This may have been a little bit tricky because we did discuss herpetiform aphthous ulcers, which present very similarly to the herpetic gingivostomatitis associated with the primary herpes infection. And a primary herpes infection often presents with an acute fever, so we need to keep those separated. I want to re-emphasize that they're just called herpetiform ulcers because they look similar. They're not actually due to herpes. So herpetiform aphthous ulcers are not due to herpes. And because of this, any kind of fever is not a likely characteristic of aphthous ulcers, making this the correct answer choice here, the wrong thing that's associated with them. We already kind of talked about the other answer choices, but let's quickly go through them again just to stress why they are correct, or incorrect in this question, but correct things associated with aphthous ulcers. And we'll start with found on unattached mucosa. This is definitely true for the majority of aphthous ulcers. The minor and major forms of these ulcers are found almost exclusively on this non-keratinized or unattached mucosa, which includes locations such as the buccal mucosa we can see for our patient's lesion. Herpetiform aphthous ulcers can technically be found on unattached mucosa, but they're not as common as the minor and major lesions and are still usually found on unattached mucosa. So this is certainly a likely characteristic for our patient's diagnosis. Next, we can take several weeks to heal. This is also something I mentioned earlier, and it's definitely true. Minor aphthous ulcers can take 7 to 14 days to heal, and major aphthous ulcers can take 2 to 6 weeks. It really depends on the size of these lesions, how many are present, and the patient's own healing ability. But this is certainly another likely characteristic for our patient's diagnosis. And finally, we have respond well to topical corticosteroids. We also discussed how this was the treatment of choice for these lesions. Topical corticosteroids are applied as this thin film multiple times per day over these lesions, and they should be applied early in the course of the lesion. These lesions respond well to topical corticosteroids because they're likely immune-mediated, and corticosteroids work to suppress the immune system. So once again, this is a final likely characteristic for our patient's diagnosis. So whenever you have this round lesion on the buccal mucosa with an erythematous halo, and they keep appearing and they keep reappearing, we know that the patient has aphthous ulcers or canker sores. And we know that aphthous ulcers are usually found on the unattached mucosa. They can take several weeks to heal, and they respond well to topical corticosteroids, but they are not accompanied by a fever. We have a 14-year-old male who says, "My lip won't stop bleeding after I cut it playing basketball. He has a history of bruising easily and excessive bleeding. There's a laceration to his upper lip that does not appear to be clotting, as well as several bruises on his arms and legs." And we're asked which test would help differentiate between hemophilia types A and B, a complete blood count, a lipid panel, clotting factor assay, or blood sugar. Now, you may see this question at first and think to yourself, I have no idea what tests they do to differentiate what type of hemophilia a patient has, and that's okay. Even if you didn't know that off the top of your head, you could answer this question logically if you know about hemophilia A and hemophilia B and know what differentiates them. You could also use some process of elimination with these other answer choices to help us narrow down to our correct answer. But let's just start by talking about what hemophilia is, and then we'll get into what differentiates the two conditions, allowing us to know the correct answer. Hemophilia is a group of inherited disorders that alter the body's ability to coagulate blood. Hemophilia A specifically is commonly known as classical hemophilia, and it's a hereditary hemorrhagic disorder that is one of the most common X-linked disorders, occurring in 1 out of every 5,000 males. Hemophilia in general is the result of a congenital deficit in a certain clotting factor, which manifests as prolonged and excessive bleeding, either spontaneously or in response to trauma, such as with our patient's cut lip. Symptoms of this condition beyond just unexplained and excessive bleeding include many larger deep bruises, pain, swelling, or tightness in the joints, blood in the urine or stool, and spontaneous nosebleeds. Dentally, this condition can present with frequent bleeding of the gingiva and excessive bleeding that is hard to control after procedures such as extractions. Treatment for this condition mainly involves replacing the clotting factor that is missing or defective, but there are other medications that can help preserve clots and promote healing. Now, what differentiates hemophilia A and hemophilia B? The two conditions are practically indistinguishable clinically due to the fact that they have the same symptoms and presentations, but hemophilia A is due to a defect in clotting factor 8, while hemophilia B is due to a defect in clotting factor 9. These two clotting factors are very similar in function, and a defect in either results in failure to achieve secondary hemostasis, resulting in a wound not clotting and continuing to bleed more and for a longer period of time. I like to keep these two factor deficiencies straight by remembering that A comes before B, just like 8 comes before 9, so hemophilia A is associated with factor 8 and hemophilia B is associated with factor 9. So now that we know hemophilia is due to a clotting factor defect, and hemophilia A and B are distinguished by defects in two different clotting factors, it should be pretty apparent that the correct answer choice here is C, a clotting factor assay. If we are able to do a test to determine what clotting factor has a defect, we would be able to know what type of hemophilia a patient has. Now, although the two have the same symptoms, knowing what type of hemophilia a patient has is really important because the condition needs to be treated by administering a replacement of the specific defective clotting factor. This clotting factor assay compares the patient's clotting time with and without the addition of specific factors, and an improvement after adding a factor indicates a deficiency in that factor, allowing the type of deficiency to be diagnosed. Now, although this answer choice is certainly the correct answer, let's go through the other answer choices and discuss what they are and what they would be used to assess. And we'll start with a complete blood count. Now, a complete blood count is actually a pretty common blood test. You've probably had one done in your life, and it's done at routine doctor's appointments. This test examines many parts of the blood, including the red blood cells, the white blood cells, the platelets, hemoglobin, and hematocrit. By examining this information, a variety of disorders can be detected, such as infections and immune system diseases, which would alter your white blood count, anemia, blood diseases, heart disease, and blood cancers. Although this test is examining the blood, a complete blood count is typically normal in a patient with hemophilia. In those with hemophilia, their red blood cells and white blood cells and other things included in a complete blood count are not affected because the specific protein factors necessary for clotting are what are defective. A complete blood count would only really show evidence of hemophilia if the patient recently had heavy bleeding, resulting in a decreased red blood and hemoglobin count. But even if this test would show evidence of hemophilia, it certainly wouldn't allow us for differentiation of hemophilia A and B, making this answer choice incorrect. Next, we have a lipid panel. This answer choice has nothing to do with blood health or clotting, so it's definitely incorrect. Now, a lipid panel is a blood test, but it examines a patient's risk for heart disease by looking at cholesterol levels and triglycerides. This test will determine the amount of good cholesterol, which is high-density lipoprotein cholesterol, versus the amount of bad cholesterol, or low-density lipoprotein cholesterol, and can help determine if the patient needs to make lifestyle changes or take medications for their heart health. Because this answer choice has nothing to do with examining clotting factors, this would also be incorrect. And finally, we have blood sugar. You should definitely be familiar with this test, as it's one you'll likely do in your dental office at one point. This test measures the amount of glucose in the blood and is an important measure for patients who are diabetic or pre-diabetic. This is commonly done by pricking the finger and using a glucometer, and diabetics often monitor their blood sugar throughout the day to make sure it's under control. Normal fasting blood glucose levels are typically between 70 and 100, and if a reading is higher than that, it indicates prediabetes or diabetes, meaning the body is either not producing or responding to insulin. But because this test also has nothing to do with clotting factors or hemophilia, this answer choice is incorrect. So we know that when talking about hemophilia, it is a condition that is due to a defect in a clotting factor. And we know that if we want to differentiate hemophilia A, which is due to a defect in clotting factor 8, from hemophilia B, which is due to a clotting factor defect in clotting factor 9, we need to do a clotting factor assay. This question is asking which is the most common benign salivary gland tumor of the parotid gland: Warthin's tumor, mucoepidermoid carcinoma, pleomorphic adenoma, or adenoid cystic carcinoma. Now, these are all salivary gland neoplasms, or tumors, that can be found in the parotid gland, but they're not all benign, and they're definitely not all the most common. The correct answer here would be C, pleomorphic adenoma. This is actually the most common salivary gland neoplasm at all, both benign or malignant. Now, this benign neoplasm is known as a benign mixed tumor due to its diverse microscopic appearance between different tumors. 80% of the time, they are found in the parotid gland, and they make up 63% of all parotid tumors. They're usually seen in those in their 4th to 6th decade and have a slight female predilection. Clinically, they are slow-growing, painless, movable, and rubbery firm on palpation. They're usually non-ulcerated, but ulceration may be present secondary to trauma. Pleomorphic adenomas are usually round when small, but become bosselated as they grow. Their treatment depends on the location, so if they are found in the parotid gland, then the lesion is removed with the involved lobe of that gland. If they're found in the submandibular gland, the whole gland is removed with the lesion. Now, these lesions are known to recur if inadequately treated, and parotid lesions are known to have more recurrences than minor glands. Now, although this is absolutely the correct answer choice, let's go through the other answer choices and discuss what they are and where they're usually seen. We'll start with Warthin's tumor. Now, this is also known as a papillary cyst adenoma lymphomatosum. Kind of understand why they call it Warthin's tumor, and it's a benign salivary gland neoplasm. It's believed to arise from salivary duct epithelium. Answer choices and discuss what they are and where they're usually seen. We'll start with Warthin's tumor. Now, this is also known as a papillary cyst adenoma lymphomatosum. Kind of understand why they call it Warthin's tumor, and it's a benign salivary gland neoplasm. It's believed to arise from salivary duct epithelium entrapped in parotid lymph nodes during development. It makes up 5% of all duct epithelium entrapped in parotid benign salivary gland neoplasm. It's believed to arise from salivary duct epithelium entrapped in parotid lymph nodes during development. It makes up 5% of all salivary gland neoplasms and 5 to 14% of all parotid gland neoplasms. It's actually the second most common benign tumor of the salivary glands behind the pleomorphic adenoma. So this is the second most common. This tumor is almost exclusively seen in the parotid gland and mostly affects those in their 6th and 7th decades. It has a strong association with cigarette smoking and is seen more often in males. Clinically, it is a non-tender, slow-growing, and freely movable lesion. It is typically seen as a firm, doughy mass in the tail of the parotid, either unilaterally or bilaterally. Treatment involves surgical excision, and the prognosis is good with a low recurrence rate. This answer choice is incorrect because this is the second most common benign salivary neoplasm, not the most common seen in the parotid. Next, we have the mucoepidermoid carcinoma. This is the most common salivary gland malignancy in both major and minor salivary glands and is therefore not a benign tumor. It is also the most common salivary gland malignancy seen in children. This is seen in a wide age range and may be found centrally within the maxilla or the mandible. It represents around 10% of all major gland tumors and is usually seen in the parotid gland. For minor salivary glands, it's mostly seen in the palate and retromolar area. It is important to note that although the lips, floor of the mouth, and tongue are common locations, mucoepidermoid carcinoma is the most common salivary gland carcinoma seen in those areas. Clinically, it is a well-demarcated or infiltrative, non-tender, fluctuant to hard lesion, and it may have a bluish tinge due to entrapped mucin. It's usually a non-ulcerated lesion, but ulceration and pain may develop as the lesion progresses. The treatment for this lesion depends on the grade. Low-grade lesions are treated with wide surgical excision, while high-grade lesions are treated with wide surgical excision and radiation. The prognosis depends on tumor size and histological grade, because remember, this is a malignancy. This is definitely incorrect, like I said, because it is a malignant tumor and is not the most common salivary gland neoplasm of the parotid. It's not benign, and it's not the most common. And last, we have the adenoid cystic carcinoma. Now, this is a malignant salivary gland neoplasm that represents 5% of all salivary gland neoplasms. And I also want to point out that this and the mucoepidermoid carcinoma are both carcinomas. A carcinoma will always be malignant, so I just wanted to point that out. Now, this has a slight female predilection and is seen most often in the 5th decade. This lesion can occur in any salivary gland, but is seen in minor salivary glands 40 to 45% of the time, with 50% of all minor salivary gland adenoid cystic carcinomas being seen in the palate. It represents 2% of parotid tumors and is the most common malignancy in the submandibular gland. Clinically, it is a slow-growing lesion that is frequently associated with pain or tenderness, which may be an early finding. So it's not something that we saw with these other lesions really, but this is normally associated with pain. The pain can be lancing and constant, and NSAIDs and acetaminophen do not help the pain. The lesion is also variably firm, is usually poorly demarcated on palpation, and it may be ulcerated. Treatment involves wide surgical excision followed by radiation, and the prognosis is generally poor as this is known to be a relentless lesion with a trend of metastasis. This is also definitely incorrect for the question, as it is a malignant tumor and is not the most common salivary gland neoplasm of the parotid. It's always important to know what the most common type of lesion and in what area they're the most common. So I definitely make sure that you know that pleomorphic adenomas are the most common benign salivary gland tumors or neoplasms of the parotid gland. We have a 5-year-old female whose mom says, "My daughter's milk teeth are falling off too fast. She has delayed motor skills, she's of short stature and has bowed legs, she has missing primary incisors, her molars have enlarged pulp chambers, and some alveolar bone loss is seen." And we're being asked, which condition is the patient likely suffering from? Dentinogenesis imperfecta, Crohn's disease, hypophosphatasia, or ectodermal dysplasia. Now, we're given a lot of clues in this patient box to be able to accurately diagnose this patient. The first clues are the non-dental clues, and this is the fact that the patient has a short stature and bowed legs. A short stature can be seen in a handful of conditions, but bowed legs is a more specific symptom, and seen in combination with that short stature, it really allows us to narrow it down. The biggest dental clue that we're given is the fact that the patient's milk teeth are falling out too fast. This premature loss of the milk teeth, or primary teeth as we usually call them, is another big indicator to the correct condition seen here. These major clues, alongside the additional smaller details such as delayed motor skills and large pulp chambers, all point to one diagnosis, and that is C, hypophosphatasia. Now let's just start by breaking down the name. Hypo would refer to something being deficient or low, and phosphatasia or phosphatase refers to the enzyme alkaline phosphatase. So individuals with this condition have some kind of deficiency with this phosphatase enzyme. In this condition specifically, individuals have a mutation affecting the ALPL gene, which encodes for the tissue nonspecific alkaline phosphatase enzyme. Now, this is a rare autosomal recessive metabolic disorder characterized by defective mineralization in both the bones and teeth. There are different types of hypophosphatasia, and they vary based off of age of onset and severity. The symptoms seen in this condition are based off of the elevated levels of inorganic pyrophosphate in the body and include bowed legs, soft bones, increased fractures, short stature, delayed bone growth and motor skills, joint pain, and fatigue. The dental manifestations include premature tooth loss, especially in the primary dentition like we see here, delayed tooth eruption, enlarged pulp chambers, enamel hypoplasia, root abnormalities, increased risk for caries, and alveolar bone loss. In very severe cases, respiratory problems and seizures may even be seen. Now, this condition is diagnosed by measuring serum alkaline phosphatase levels, and there's currently no cure available for the disease. Treatment includes enzyme replacement therapy, nutritional supplements, and supportive care. Now, because this patient has that short stature, bowed legs, delayed motor skills, and because her primary teeth are falling out too early and her pulp chambers are enlarged, we knew that she has hypophosphatasia. Now, let's go through the other answer choices and talk about what each condition is and how we knew it was wrong for this patient. Remember, when deciding what condition a patient has, it's just as important to keep in mind what symptoms they are not presenting with. So let's start with dentinogenesis imperfecta. Now, this condition specifically refers to the formation of faulty dentin, which is why it's called dentinogenesis imperfecta. It's imperfect dentin. Now, this is an uncommon autosomal dominant condition due to a mutation in the DSPP gene, or dentosialophosphoprotein gene, one of the major non-collagenous proteins of dentin. Clinically, the teeth in a patient with this condition will appear translucent or opalescent, which you can see in this picture, and both the primary and secondary dentition are affected. The enamel is normal in this condition as it only affects the dentin, but it will be poorly supported and rapid attrition of the dentition is often seen. Radiographically, this condition is characterized by bulbous crowns and obliteration of the pulp. Now, management of this condition depends on the severity of the gene expression, and it may require little restorative care, but implants or overdentures are usually necessary in many cases. Now, we knew this was not the correct answer choice because dentinogenesis imperfecta does not cause short stature, bowed legs, or any of the dental findings seen in this patient. Rather than seeing enlarged pulp chambers, we would actually see obliterated pulp chambers in these patients, and the teeth would also present with a characteristic translucence or opalescence. Because the teeth do not present this way, and because there are no bulbous crowns or attrition of the dentition seen, we knew that this was not the condition for this patient. Next, we have Crohn's disease. Now, Crohn's disease is a chronic inflammatory bowel disease that can affect the entire gastrointestinal tract. The condition is characterized by swelling and inflammation of the digestive tract and is of unknown etiology. It's associated with an altered immune response and has a strong genetic association, but since the etiology and pathogenesis are not completely understood, it's often difficult to get an early diagnosis for a patient. This condition is known to have periods of remission and exacerbation and often comes with various complications. The main symptoms that raise suspicion of Crohn's disease are often chronic diarrhea, especially with blood present, coupled with abdominal pain and cramping. Other symptoms include weight loss due to that diarrhea, fatigue, malnutrition, and oral presentations. The oral presentations for Crohn's are numerous and often present as the first manifestations of the disease. Early oral symptoms include redness, edema, pain, and other pathognomonic oral lesions for Crohn's disease include cobblestoning of the oral mucosa, deep linear ulcers in the fold between the cheek and gum, and mucosal tags or polyps. As far as treatment, there is currently no cure for Crohn's disease, and the condition is honestly pretty difficult to treat as there is no single treatment that works for everyone. The goals of treatment are often to reduce the inflammation that triggers the signs and symptoms, as well as to improve long-term prognosis by limiting complications. The most common treatment is corticosteroids, which can help reduce inflammation and induce remission. But these drugs are often given in combination with an immune system suppressor, and other drugs are often given for symptomatic care, such as pain medications or antidiarrheals. Now, we also knew that this was not the correct answer choice because Crohn's disease does not impact the bones and therefore does not cause any bowing or short stature. Crohn's disease can also have oral manifestations, but it does not directly affect the teeth or oral mucosa, so we would not see enlarged pulps or early loss of primary teeth in patients with this condition. Now, our patient also did not present with any chronic diarrhea or abdominal pain, so we knew that she did not have Crohn's disease and that this answer choice was incorrect. And then finally, we have ectodermal dysplasia. Now, this developmental condition is a group of inherited disorders in which two or more ectodermally derived structures do not develop normally or fail to develop. This condition has several patterns of inheritance depending on the type, and it's characterized by hypoplasia or aplasia of the skin, hair, nails, teeth, and sweat glands, which are all ectodermally derived structures. Clinical features include fine, blonde, or light-colored hair, periocular hyperpigmentation, heat intolerance due to lack of sweat glands, protuberant lips, a prominent forehead, varying degrees of xerostomia, brittle nails, hypodontia or oligodontia, abnormally shaped crowns, and teeth with conical roots. Now, treatment for this condition includes genetic counseling for patients and parents and will likely include fixed, removable, implants, and orthodontics depending on the individual case. Now, we knew this answer choice was incorrect because it is not associated with any of the findings seen in our patient, like the short stature or bowed legs. Because bones are not ectodermally derived structures, they are not affected in ectodermal dysplasia, so we would not see these symptoms. Our patient also does not present with symptoms that we would expect to see in a patient with ectodermal dysplasia, like fine hair, lack of sweat glands, hypodontia or oligodontia, and conical teeth. And because of this, we knew that this answer choice was not correct. So when a patient presents with short stature, bowed legs, and their primary teeth are lost early on, we know that they are suffering from hypophosphatasia.
In this scenario here, we have a 19-year-old female whose chief complaint is that the left side of her face is swelling. And upon clinical examination, we do see that hard swelling around the maxillary canines, but the patient isn't experiencing any pain or discomfort. If we take a look at the radiograph, we can see expansion of the buccal and lingual cortices, which would explain the swelling, and then we can also see that the lesion appears to be radiolucent, so this might indicate that it's some type of cyst. So the patient is presenting with a dentigerous cyst, and this will look like a unilocular radiolucency that's surrounded by a well-defined radioopaque border. The lesion will appear to expand the cortices, which is why we're seeing that buccal and lingual expansion. And most importantly, it'll occur around an unerupted or impacted tooth and attach at the CEJ. The dentigerous cyst is asymptomatic, and all of these are consistent with what the patient is reporting. So I'll take a look at the other options to determine why they are wrong. The ameloblastoma is a benign odontogenic tumor, and we can immediately eliminate this option because it generally appears as a multilocular radiolucency with radioopaque septa, which is not what we're seeing with the patient's radiograph. Instead, it'll look something like what we're seeing here in the red box. There might also be a variant called the unicystic ameloblastoma, which can have a similar radiographic appearance but will appear unilocular. Ameloblastomas are generally asymptomatic, but if they get large, they can present with swelling like what we're seeing with the patient, but we know that this answer is incorrect because of the radiographic appearance. Next, we have an OKC, and we note that this is an incorrect answer because although it will present as a radiolucency, this radiolucency will be multilocular and also have scallop borders around the teeth like we're seeing in this radiograph. An OKC can also sometimes be associated with unerupted teeth, just like with a dentigerous cyst, but it does not always have to be associated with teeth. And if it is found around a tooth, it can be found at the CEJ like the dentigerous cyst, but it can also be found in other locations like the apex or lateral to the root. OKC can sometimes be asymptomatic, or once again, it can also present with swelling of the cortical plates. And if multiple are found in a patient, we might suspect that they have something known as the nevoid basal cell syndrome. Finally, we have the nasopalatine duct cyst, which will present as radiolucent, but as the name describes, it'll occur in the nasopalatine duct. So this means that it'll be located by the roots of the maxillary central incisors and not by the canine like the patient is describing. It will usually be asymptomatic, but we can also sometimes have swelling on the palate and not the side of the face like the patient is experiencing. So now we know what all these pathologies look like clinically and radiographically.
This question asks, each of the following is an advantage of digital radiography compared to conventional radiography except one. So let's look at our answer choices. First, we have option B, no special room required. This is true, as with the transfer to digital radiography, there is no need for a dark room for processing. Next, we have ease of processing. This is also not true, as we simply can just click a button and the radiograph appears on our computer. So this is not the correct answer, as this is a very easy change from digital radiography. Next, we have an immediate image. For the same reason stated before, simply with the click of a button, we're able to see our radiograph on our computer. So this is also an advantage. Finally, we have patient comfort. This is the false statement because digital radiographic sensors are actually much larger and bulkier than the conventional radiograph sensors such as phosphorus plates. So option A, patient comfort, is the correct answer to this question.
Now this question is pretty straightforward and it's all about the phenomena fusion. So let's go ahead and talk about it. It's asking each of the following is associated with fusion except one. Which one is the exception? So first let's talk about what fusion is before we go through these answer choices. Now fusion is a variation in the shape of a tooth where we get a bifid appearance, and you can see that in this picture. And this is due to two tooth buds merging. And as a result of these two tooth buds merging, we get a single larger tooth, and you can see that once again in the picture. Notice how it's called fusion. You have these two tooth buds fusing or merging together. Now, fused teeth will have separate pulp canals and separate pulp chambers, but they will share cementum and dentin. So if you went below the gum line, you would see these separate roots with these separate pulp chambers, separate pulp canals, and then when you come up into the crowns clinically, you can see that they are two separate crowns that have merged together, but they share that dentin, they share that cementum. So that's an important detail. Now let's go ahead and just talk about what the answer choices are. It either affects only the permanent dentition, results in one less tooth in the arch, anterior teeth are the most commonly involved, or it may result in complete or incomplete fusion. Now, 3 of these are true and 1 is false. And the one that is false is the fact that this affects only the permanent dentition. This is actually seen in both the permanent and the primary dentition, and it's actually more common in primary teeth than in permanent teeth. So that answer is definitely wrong, which means all the other ones are true. So let's go ahead and talk about them. Now, the fact that this results in one less tooth in the arch is actually a really important detail about fusion, and it allows us to distinguish it from other similar findings like gemination. So how this works is that you have two teeth, like we said, two tooth buds that fuse into one. So say this person has 28 teeth, we won't count their wisdom teeth. If we go to count the individual teeth that we see in the mouth, we would only see 27. We wouldn't see 28, and that's because these two crowns have fused or merged together. So this will always result in one less tooth in the arch, while other conditions like gemination don't cause that effect. So this is a really diagnostic fact for fusion, and it's definitely something important to know and could come up in other questions. Now, anterior teeth are the most commonly involved. That's also true. So like I said, we see this more commonly in primary teeth, but we also see this more commonly in anterior teeth. And actually the most common tooth to be affected would be your mandibular anterior, as you can see in this picture. So anterior teeth are definitely the most commonly involved. And lastly, the fact that this may result in complete or incomplete fusion. I have attached a different picture from the other pictures we were seeing just so you can see how fusion presents. So you can see here we see a little bit different of that fusion. This person actually has 2 separate incidences of fusion in their mouth. Now, this can definitely result in complete or incomplete fusion, if that makes sense. You can definitely see a variation. So it's definitely something that we can see in fusion, so that is absolutely true. It definitely ranges in each incidence that we see it, but you can have complete or incomplete fusion when teeth do fuse together. It just depends on how far along in the development the 2 tooth buds are when they fuse or merge together. So when we're talking about fusion, when we're seeing those 2 tooth buds merging or fusing together, all of these are true. We always see one less tooth in the arch. The anterior teeth are the most commonly involved, and you may get complete or incomplete fusion, but it affects both the primary and the permanent dentition, and it's definitely something to know.